Good afternoon and welcome. Happy Valentine's Day. Happy Congenital Heart Defect Awareness Day, February 14th, 2012. My name is Mary Ellen Mannix with James's Project. I'll be doing most of the presenting this afternoon. However, lurking safely in the background but doing a lot of work is Christine Brighton McCormick of Cora's Story. She will be answering questions for the first 20 minutes. On the right hand of your screen, you'll see some buttons, and on the bottom of it, there's a question box. You can type in any of your questions as we're talking, and Christine will be able to answer them. In addition, Christine will be answering questions in a Twitter chat. You can find her Twitter handle at Christine Bright. Just a couple more housekeeping issues before we get into talking about pulse oximetry 101 and congenital heart defect screening. Again, we're taking the questions for the first 20 minutes through our question box and Twitter. The last 10 minutes, we'll open it up to general questions. Again, you'll need to type them into your question box, but I'll answer them live on audio. This webinar will be available through a recording in the next 2 weeks or so at our host site, Baby's First Test. It would be babiesfirsttest.com, and they are graciously sponsoring this webinar today. We also have a couple prizes, and Christine's going to be managing that. Again, we encourage you to ask questions, get involved, share us your thoughts and concerns. If you do not have a Twitter handle to share your questions, you could also email them to Christine at corasstory.org. So thank you again for joining us. This is Christine Bright McCormick and her beautiful daughter, Cora. Cora passed away 2 years ago, a little bit more than 2 years ago, from an undiagnosed CHD. She was 5 days old, and Christine has led a very strong mission from her home and from her heart to make sure that nobody else has to go through the trauma that she has experienced of an undiagnosed heart defect. On the right-hand side is me. My name is Mary Ellen Mannix, and you can't see him very well, but that's my little guy, James. He was born 10 years ago, and he passed away from complications and errors in the treatment of a congenital heart defect. So this first newborn screening that we're discussing today is very near and dear to both of our hearts. However, keeping babies safe is the most vital part of our presentation to you, and why we've collaborated with Baby's First Test through a challenge grant that they have awarded to us to help you understand the importance of newborn screening in your child's health. They're a wonderful resource that is one of the HRSA programs down in Washington, D.C. The prizes that Christine will be sharing today are from Earth Mama Angel Baby and Robin Weiss. So we're very grateful to their, and this is what you're going to be able to do. Hopefully by the time we are finished this webinar, you will understand what pulse ox is. You may have heard a lot about pulse ox in the past 1.5 to 2 years. Pulse oximetry is the technical term, and it is very often used abbreviated as pulse ox. You will understand why pulse ox is a vital newborn screening tool and be able to advocate for your baby to receive this screening. We also hope that you will be able to use Baby's First Test to find out if your state screens for critical congenital heart disease. That is what the CCHD stands for. Here are a few pictures of pulse ox being used on adults. You probably have used this yourself if you've ever had a loved one in the hospital or even visit the ER. You probably had one of these probes just clipped on your finger. And if you'll remember, it's not invasive. There's no needle stick or prick or anything like that. The way it works is basically it is measuring through an infrared probe. It is measuring the oxygenation level of your blood. Here are some of your newborn pulse ox probes. And you can see the little light on the upper left. You see it on the bottom of the foot. And you can see the pink kind of sticking out a little bit. That's the pink light glowing. On the bottom, that's another one done on the lower extremity. Again, these are kind of bandaged around the foot. It does not invade the skin at all. And then you also have the one on the upper extremity, on the cute little girl there. She's just grabbing it with her fist. Again, it's the same tool, completely non-invasive. This pulse oximetry actually dates back to the 1970s. And again, it's measuring this oxygen saturation level in your blood. It's been a very useful tool for clinicians. And what I'd also like you to understand, I apologize not getting this away in housekeeping, but Christine and I, neither one of us are medically trained. We're not clinicians, and all of this information is not at all meant to replace a conversation that you would want to have with your pediatrician or your obstetrician or your OB/GYN or your pediatric cardiologist. What we hope this does is give you some additional information to be able to bring into a conversation that you'll have with your clinicians. When they go through their day, they're seeing multiple patients. They are taking in gross amounts of information from the needs of individuals all the way to their professional society as a whole, and trying to stay up with the most up-to-date work. Sometimes they may think that they've addressed all of your questions, and you may not have actually been able to formulate a question from the limited information that you may have received. We hope this is a tool so that you'll be able to formulate some additional questions and have a really in-depth conversation with your child's clinician, with your clinicians, about how this tool may be beneficial for your child. It has been referred to as the fifth vital sign. Now, this is certainly not at all intended to replace the clinical exam of a physician of a newborn child. They definitely, and I've heard pediatricians say, and it's actually beautiful to hear how they speak about looking at the whole baby and being present and just looking top to bottom, inside out, front side, back side. And the fifth vital sign, this measurement, you know, clinicians don't always like, the experience that I've had in speaking with them, to have some of these tools interfere with that ability to make a personal connection with their patient and the patient's family. So what this does, even though it is technology, it is an extra data point. This is another piece of information that they can take to add to their clinical exam and make an appropriate decision as to what could happen next for your child. As we saw in the earlier slides, go back a couple, with your older population, this really is used throughout medical care today. They may keep it on you, as you go in the ER and are being triaged. You may see, if you go and visit a friend who is there for, an outpatient procedure, have a pulse ox on them. This may be used in the OR, it may be used out of the OR, it may be used in, again, throughout whatever the setting is in healthcare. This is somewhat of a standard tool to see. And it is definitely helpful to start getting an idea, some more information from these new patients that have just arrived and what their very unique and individual needs are. This is just one extra little data point to help them come through. Again, this is not invasive. It doesn't hurt. The protocols that HRSA put out last year does include that they would like the child to be calm but not asleep. So this would actually speak for an opportune time. If it's possible, mom could or dad could be holding the baby while the pulse oximetry is being done. But it is, that's a very tricky time for the clinicians to get. Think about a newborn. And in this picture, you can even see that this little guy does look like he's asleep. So it's a very difficult time to try to get when the child is not sleeping, but also not crying. They would like the child to be calm, because once the child is crying, they do become, it can make the pulse ox reading a little off. As we go on, I'd like to discuss a little bit about why we're talking about pulse oximetry exactly and why today. CHDs, mentioned earlier as CCHDs, there's a difference. Congenital heart defects, as you see here, are the most common birth defect. They have suggestion of about 1 in 100 babies born with a CHD. You may be able to find elsewhere, your OBGYN may tell you, as mine did, that Down syndrome happens in about 1 in 800 to 1 in 900 occurrences. So that gives you an idea of the frequency with which this is happening. Not all CHDs are critical. Not all CHDs require immediate invasive intervention. However, the critical CHDs, which occur in about 1 to 2 of every 1,000 live births, will probably need some immediate intervention. What pulse oximetry screening is trying to do is keep these babies from going home undiagnosed. Once you have some data and you have some information, then you have a way to share information, make an appropriate decision, and actually get that engagement with yourself and the clinician to make the best decision for the child and what should happen first. Pulse oximetry is known to screen and catch possibly about 7 different critical congenital heart defects. Some of the ones that it does not catch are coarctation of the aorta, for instance. It may not catch that. However, it will catch tetralogy of Fallot. Now, there's 32 plus different congenital heart defects. Leaving the hospital without having any information makes it a little bit more difficult to do any search and find out any additional information about what your baby needs. Having the pulse ox reading to find out exactly how the oxygen is working or getting through the blood and through the body for your child is very helpful. We look back again. We're going to go back to the babies. And if you notice here, there's a pulse ox on the foot and pulse ox on the hand. Getting both readings, if there's a variant and a difference, can be helpful information to a clinician, depending upon how much oxygen is being read from the upper extremity compared to the lower extremity. This information is helpful to a pediatric cardiologist and a primary care physician in deciding if this is something that needs further evaluation. So again, congenital heart defects being the most common birth defect. Sounds pretty scary, doesn't it? For your child to be born with a heart defect. In the past 10 years, I've been happy to see a change that Well, actually, you can go back 20 years or more that there have been options for children with the most critical of these defects for treatment. In the late 70s, early 80s, the most critical, which is often referred to as HLHS, hypoplastic left heart syndrome, one of the options was compassionate care, and the other option was possibly counseling to termination. Now there's options. Physicians in the mid-80s and 90s created a 3-step procedure which has actually been further refined to give these children a wonderful chance at life, and more of these children are living into their adulthood than ever did before, and they require treatment. And it requires knowing that there is something there to treat. When the babies go home undiagnosed, then it's up to mom and dad and a primary care physician and pediatrician to figure out what might be happening. So it's helpful to know what some of the signs and symptoms of these defects are. Baby's First Test has developed a beautiful website where you can look yourself to find out some more information about critical congenital heart defects, about their signs, about their symptoms, about the incidences of which they occur, as well as whether or not your state is requiring screening for this defect. As of last September, this past fall, 2011, screening for CCHDs was placed on the federal recommended universal screening protocol panel. Thanks to a lot of work from parents, including one Anna Marie Saarinen and others, this has gotten to where we need more information to go so that you are able to help engage with the clinicians and find out. Some of the evidence that pushed forward that successful implementation, and that implementation of putting CCHD on the RUSP so quickly came with this kind of evidence. If you see in Sweden a very large population sample, and again another one in England, this 39,000, 35,000, these samples helped show that using pulse oximetry to screen for CCHD was very successful, and the few false positives tended to have children who had another condition that was worth follow-up, that it was very helpful that they knew that there was something else going on. When you want to get pulse ox to babies, you need to realize this is a point-of-care newborn screening. It's a relatively new model. Newborn screening has been around for 50 years. Actually, next year it celebrates its 50th birthday. But CCHD screening is just in its first year. Currently, there's legislation that has been enacted and implemented in Indiana, New Jersey, and Maryland. There's been some introduced or pending in a number of other states, including Florida, Pennsylvania, I believe New York. And there are federal and state recommendations, which is what the RUSP was able to do. The consumer demand really pushed this forward, and this is where using sites like Baby's First Test, which again is hosted by HRSA, an evidence-based resource for you when there's so much information coming at young parents now. You need to understand that you want to get information from a reliable source. Your clinicians are absolutely your reliable source. Sometimes with their crazy busy schedules, you're wanting to find out at 2 o'clock in the morning what a sign and symptom is, and you're afraid to call and use 911 or call their emergency line. Let me just tell you, as a parent of 5 children, always better to be safe and a little embarrassed than sorry later. If the clinician has given you the tool to access them, absolutely utilize that. If you're doing some research on your own, Baby's First Test is a really great place to review some of this information. Really quick, I wanted to go back to that consumer demand because I can't say strongly enough how parents like Anna Marie Saarinen, Kristen Spiker, there's so many that I'm afraid I'm gonna miss somebody. But we've brought that to using their specialties that they were trained in for other things, and then when these moms had this personal experience themselves, they used their talent into this mission to drive this forward, and with the cooperation and support of some key vital clinicians, we've gotten to this point where now we're sharing this information. This screening is getting to the touch point of newborn care right at the newborn isolate, and we can get these answers and help these babies sooner than later. So you can find out, again, if your state is screening by visiting Baby's First Test, pick the condition screen by state, and click under About Newborn Screening for the drop-down menu, and you're going to be able to find out what's going on in your state. For more information about that, you can also resource Christine Bright McCormick. She has a site also that is following some of this in coordination with 1 in 100, and of course my site will also update some of this. Here is one of their maps where you'll be able to click on, very user-friendly. Now, here's where you're going to find your critical congenital heart disease. It's found under other disorders. And you see there's a list of other disorders that we are screening for in newborns. We are going to be continuing to discuss newborn screening in the next 6 to 8 months. This is our first webinar. And following, we're going to talk about some of these other ones as we move forward. And if your child perhaps doesn't have a CCHD, or you're pregnant right now and you've had a different prenatal diagnosis, or you're home and it's 2 weeks in and you have some questions about what's going on with your baby, you might be able to look up some things here. Or perhaps the physician has told you, this is what I think we may be looking at with your child. Ask them to spell it and jot it down, and you can come back to this website and be able to get some more specific information about that. The signs and symptoms for the CHDs. These are the babies that we are remembering and honoring today, which across the nation is being recognized as Congenital Heart Awareness Day. It has been for at least, I believe, 10 to 15 years, thanks to the work of the Congenital Heart Information Network. Some of the signs and symptoms of CHDs: your newborn may tire easily. Now that sounds a little silly. It may be a sign of something else. But let's put it together that your child also seems really pale, or there's a bluish tint to their skin. Also might seem a little silly, like the symptom could actually be because the child is, like my kids are, very pale to begin with. I can't go outside without about 50 sunblocks, so my kids are always very pale. But let's put that together again. Your child may make some grunt-like sounds when eating, just something different. But again, maybe he's just hungry, he can't get it down fast enough. But then also the chest. You're seeing the chest kind of contract in very deeply when breathing. I mean, you can notice this. And their extremities may feel cold. You may see some of this. You may see all of them. Anytime you have a question, you think, you know what, your child, let's say your child only tires easily. Doesn't seem pale at all, no bluish tint. Child doesn't make a sound when he's eating, and he's not contracting, and the hands aren't that cold, but you have a sense or a feeling like, I'm not sure about this. That would be a great time to pick up the phone and have a chat with your clinician. Let them guide you through whatever symptoms you may have, your child may have, but you definitely want to be engaging and having a conversation with the pediatricians in your child's life, so that you can help promote a very safe outcome for your child. So we're so glad you were able to be here today. I hope that this information was helpful. I hope it wasn't too repetitive. Remember to follow us on Twitter, Facebook. Our blogs are listed below, as well as the Twitter handles. Baby's First Test also has a blog that you can find on its website. And if you have any questions, this would be a great time to shoot them out, and we can answer them. But here are some for you. What does a pulse ox measure? Now remember, if we go back to the beginning of the webinar, we were looking at the pulse ox that was put on the finger or on the hand, on the hands, on the foot, and that little red probe was glowing. That's measuring the oxygen saturation in your baby's blood. When is it most effective to implement the pulse ox screening? So glad somebody asked. In any event, that is most effective 24 hours after birth. So not within the first 24 hours. It is most effective after 24 hours, and your clinician will be able to explain to you why that is, why you want to wait 24 hours. What condition does this pulse ox screen for? Well, remember, it's Happy Hearts Day. It's all about congenital heart defects today. But what happens if you get your child fails the test? Does it mean it definitely is a congenital heart defect? It may not be. There may be another simple reason for the low reading, but you definitely want to have some further evaluation and follow-up. Is a pulse ox screening 100% effective? So anybody who passes it, does that mean that baby absolutely, definitely does not have a congenital heart defect? Nope. That child could have a congenital heart defect. And that's why it is important to remember some of the signs and symptoms that we went over a couple slides ago. What are the signs and symptoms to look for in case the pulse ox screening has not identified a hidden condition? And that's back again a couple slides, and I think it's worth looking at. Tires easily, pale or bluish, you may make grunt sounds, chest contracts when breathing, cold extremities. Again, Baby's First Test would be a wonderful resource for you to refer to if you have any questions, and always check in with your clinician. Are there any other questions before we wrap this up? Remember, you want to follow Christine Bright on her Twitter handle at Christine McCormick. She's taking questions and answers over there, and hopefully you're engaged. We want you to be engaged because we want you to get engaged with your pediatricians and clinicians as well. And over there with Christine, you'll be able to win a few prizes. Thank you so much for being here today. Again, if you would like to find out more information, you can find more about Cora and Christine's work at www.corastory.org. You can find out more about myself and James's project at www.jamesproject.com. Now I am seeing a couple of questions. Awesome. How does point-of-care newborn screening different from other models? Great question. And I see somebody has gone ahead and answered that. Thank you very much. But I think we've pretty much gotten everything. So remember, the difference between newborn, between point-of-care screening and the other model of screening is the heel prick test, where your child will have a drop of blood that will be put on a filter paper, and that will be tested for a variety of metabolic issues. There's no blood test for CHDs. This, ironically, for the heart, we're measuring the oxygen saturation level in the blood. You don't have to put any kind of heel prick or stick at any point in the child to find that out. So again, Baby's First Test is a wonderful resource for you. Please check it out at www.babiesfirsttest.com. Thanks very much, and we hope to see you at our next one. Make sure you're following so you'll find out when it is.